Thank you for joining us for the Conversation with Impact webinar on the subject of conversations with women ages 40 and over, breast cancer, colorectal, and cervical cancer prevention, as well as to learn when specific screenings are no longer needed. Funding for this activity is made possible in part by the U.S. Department of Health and Human Services Offices on Women's Health. The American Cancer Society is a co-provider for this event. The education program has been approved for 1 contact hour for nurses, and to be eligible, you must attend 80% of the webinar and complete all of the information on the Zoomerang evaluation survey and return it. At the end of the presentation, I will give a code word that you must insert on the evaluation. You will be sent a certificate via email at a future date. Before I introduce our speaker, I would like to let you know that if you have a question during the presentation, go to the toolbar chat box and type in your question and click on the arrow to have the question go to the presenter. Our presenter today is Terry Gibbs, DO, a ProMedica physician with 28 years of experience in OBGYN. He is a certified North American menopause practitioner, providing multiple presentations on the topic of women's health issues. Thank you for presenting on this very important topic for us today, Doctor.
Thanks for the invitation, and thanks for everybody's patience while I got set up. I'm not real good at this, but we got through it. We actually practiced this. Bev, do I come across okay? Do you think people can hear this?
I hear you just fine.
Okay, good. Well, today my objectives today is to discuss the importance of cervical cancer prevention, breast cancer prevention, and colorectal cancer prevention in women ages 40 and older. All of my comments will be directed to women who are 40 and older. And when we talk about prevention, that's becoming the thought leaders in the area of obstetrics and gynecology and even oncology really are looking at prevention to be a real key thing in the future. Pretty much our American system has been based on waiting till people get sick and then seeing them, and really never focused on prevention. However, that's changing, and we are finding that emphasis on prevention can definitely save lives. And there I am years ago. So in order to prevent a disease, the 2 things I really want to focus on, you can talk a lot about prevention, but the 2 things I want to focus on with you today is, number 1, looking at risk factors that make for the disease and modifying them to lower the risk of that disease. And as a part of that, we utilize testing to try to detect disease in asymptomatic women. That's called screening. And then also the use of medications or procedures that also lower the risk of symptomatic disease. When we say prevention of a disease, we're including in that people that maybe have an early stage of a disease, but we're interested in finding the disease before it becomes symptomatic. Because when it becomes symptomatic, it's definitely more advanced. First, I'm going to talk about cervical cancer prevention. And a couple of things about cervical cancer that should be understood. Number 1, it's different than the breast and colon in that it's an acquired, by and large, it's an acquired issue. There are certain types of rarer cervical cancers that can happen for reasons we don't understand, but most of cervical cancer happens because of people acquiring human papilloma virus. And when we do a pap smear on somebody, if they do not have the human papilloma virus, we're not too worried. And there's a lot of different types of human papillomavirus, in fact, over 100. But there's only about 14 to 16 that are actually able to cause cancer. And so we want to understand cervical cancer as a problem that's acquired. And I want to go over with you screening, the screening guidelines from 3 different societies. First, the American Cancer Society, and I'm going to go through these rather quickly because I'm going to make some points at the end of them. First of all, cytology alone, and that's doing just reaching in with a brush and rubbing some cells off the cervix and putting it either on a slide or in some fluid, which is called thin prep. Cytology in HPV is doing the same thing, but putting them only in the thin prep solution. From the thin prep solution, they can test to see if there's any of the high-risk human papillomaviruses. And so that's what those 2 are about. Now, if you do cytology alone, they recommend it every 3 years. Now, remember, these comments are about women 40 and older, period. Cytology in HPV, you can do pap smears every 5 years. To stop pap smears, they recommend stopping pap smears at 65 if there's a negative history. In other words, all pap smears have been normal, or 20 years after regression of a positive test. In other words, you got a bad pap smear. They want to wait, or they're saying that they want you to wait 20 years until that pap smear turns normal again before you absolutely stop pap smears. Then their final point is to stop pap smears after people get hysterectomies, especially if the hysterectomy is for a benign reason. In other words, there's no bad pap smear, they don't have some kind of bad pap smear that caused them to have this hysterectomy or a cancer. Now, also the guidelines, some people will get hysterectomies today where they actually leave the cervix, or supracervical hysterectomy. And if you leave the cervix, even though you've taken the rest of the uterus out, you still want to follow the guidelines as noted above, and not stop pap smears because of just because the rest of the uterus is gone. That's the American Cancer Society guidelines. The U.S. Preventive Task Force, they recommend, again, cytology alone for every 3, cytology plus HPV every 5. Again, stop at 65 if there's a negative history that people have never had a bad pap smear, and stop after a hysterectomy is done for negative history. They don't put many provisions in, like the American Cancer Society did, regarding people getting, if people have had a bad pap smear. And that's kind of the rub a lot of us have, is just how long do we want to watch somebody who's had an abnormal pap smear. The American Cancer Society answers this, as well as the American College of OBGYNs. Now, the OBGYN College recommends cytology alone 3 years if 3 consecutive negatives. What they recommend is at 40, people are getting 3 pap smears in a row that are negative. Then you can go to every 3 years. Cytology plus HPV, if you do that, then you can do every 3 years if both are negative. And then stopping at 65 to 70 after 3 negative pap smears, or no abnormals for 10 years. Now, here again, they put in a statement about, say, a woman loses a husband and remarries, and she becomes sexually active again. What about them? The American College is the only people that say to continue watching pap smears in this age group if they get a new sexual partner. Now, people are not convinced about doing this. Even at this age, with a uterus, with a cervix, it is harder to develop an abnormal pap smear just because of the changes on the cervix. It becomes a lot more resistant to picking up this HPV, so that's controversial. And then finally, stopping pap smears after hysterectomy if there is a negative history. A couple things I want to note about all of these, looking at all these guidelines. Number one, yearly pap smears are no longer recommended. Now, we've been doing yearly pap smears until, since in the beginning. And to change people's expectations is going to take some work. They're slowing it down because the thing about getting HPV and developing an abnormal pap smear and it developing into cancer does take a long time and takes years to develop cancer from HPV. And we know a lot more about the science of what happens, about the biology of this HPV, and yearly pap smears are no longer warranted. And so that's one big change that I think a lot of the gynecologists are trying to change to, but it's hard to break a bad habit, especially we're trying to explain this to patients who've always had yearly paps. But we understand a lot more about the biology now, and really yearly testing is no longer recommended. And this HPV testing has become very helpful in helping us triage people. Sometimes you get an abnormal, but you check the HPV and it's negative. So you don't really worry about these people developing anything bad. The other big point in all of these guidelines is that there is an endpoint to doing pap smears. As people age, again, their biologic ability to get infected with HPV and develop cervical cancer really changes. And so we see, and especially in somebody who's had a hysterectomy, it really is hard to see an abnormal pap smear based on the vaginal smears. I've seen it. It happens, but very infrequently. And so there are exceptions to all these guidelines, but these are the guidelines. And if you're, somebody with not a significant history of an abnormal pap smear or have some special problem like, HIV people, people with that infection, these guidelines are not appropriate for them. So I want to make just a few other points about cervical cancer prevention. Is number one, in order to really fulfill these guidelines, the other thing I'm really endeavoring to do today is to get people to separate the idea of the pap and pelvic. Forever and a day, you come to the doctor and you say, I'm here for my pap and pelvic. And with the doctor saying, gosh, you no longer need annual pap smears, people infer that is, well, I don't need to see the doctor every year. He said every 3, so I'll only go every 3 years. And that is not what we're saying. We need to separate the concept of the pap from the pelvic. As people age, we're not going to do as many paps. But as people age, the need to have a pelvic becomes more important. At the age of 40 and beyond, having a pelvic exam becomes paramount, because that's the age, that's the decade where women start to grow things on the inside, and that's certainly when you can start to pick up problems that people have. So you may not be doing a pap smear on them, but you're looking for other things. The emphasis changes as you pass 40. And I want to make a statement about today we're giving a lot of our kids the Gardasil to protect them against this HPV. And I think in time we'll know more about how this has affected kids, and we'll see the HPV infection numbers go down. But as for right now, people getting the HPV vaccination still should follow the above stated guidelines. That will probably change one day, but for now, follow the given guidelines. And finally, regarding, we've talked about risk factors and how people get these abnormal pap smears. The one lifestyle change people can make is safe sex practices. And here again, you can't pick this up if you're not having intercourse. And I mean, there's reported cases of people getting it from something we call fomites, some weird thing happened, like the picking it up from a towel. I mean, that's been reported, but by and large, HPV is picked up through intimacy. And most people are not going to avoid intimacy, and so you recommend the use of latex condoms. And really, we mean latex because most condoms will allow HPV particles to pass through them, but HPV will not, or I'm sorry, latex will not. It's one material that will not let the viral particles pass through them. So you got to use a particular kind of condom, and you pray that it doesn't break. So let's move on to breast cancer. And what we're going to talk about again is risk factors, and then we'll get into the guidelines. There's a number of non-modifiable risk factors that you've got to think about when you're thinking about how do I prevent breast cancer. Gender is one of them. If you're a woman, you have 100 times more of a chance than a man to get breast cancer. Men do get breast cancer, but a lot less often. Age is a factor. We all know people who are under 50 who've had breast cancer, but 2 out of 3 invasive cancers are in women over the age of 55. Genetic risk and family history are very important. People that have genetic problems, which I will be talking about in more detail, explain about 5 to 10% of all breast cancer. People with genetic special genes really account for about 5 to 10% of the of breast cancer. And then in your family history, just having close relatives, your mother, your sister, having breast cancer, even if you prove not to have these special genes, really do, just those facts alone really raise the risk of you having cancer. Certainly having a personal history of breast cancer is another one because it can recur. Ethnicity, we see white and the black population having more breast cancer than the Asian and Hispanic populations. Dense breast tissue is thought to be another risk factor that's non-modifiable. If you have a lot of breast tissue and it's very thick, I mean, the more tissue you have, the more chance you have, is what it comes down to. If you have very little breast tissue, then the chances are smaller. This is reported a lot on our mammograms from the ProMedica system. A lot of times the reports that come back to us, the report will read that they recommend a different type of testing, maybe MRI or something, in women with very dense tissue. And sometimes women will get a call and somebody will say, they want you to do an MRI of your breast, and people say, oh my God, what's wrong? And a lot of times it's just because you have breast tissue that's very dense. So that's another issue. You have benign breast conditions like something called atypical hyperplasia, but that's something that the doctor, somebody would tell you about after a biopsy. Also, menstrual periods, people who start menstrual cycles very early in their life or end them very late. You're a real early you go through, you get your first your first period at 11 or something, and your last period at 55, you have a higher risk of breast cancer. You have more time. The feeling is that you've had greater exposure to estrogen. Also, previous chest radiation, children with, this is especially true of children, people who've been radiated in the chest because of like Hodgkin's lymphoma are at higher risk. And then finally, DES, or diethylstilbestrol exposure. This stuff was around in the 40s to about the 70s, and there is an increased risk of breast cancer with this, but we just don't see many of these folks anymore. We just don't see this very often. And then we want to go to modifiable risk factors. First of all, childbirth. People who have their children late have a little bit higher risk of breast cancer. Oral contraception. There's a very slight risk, but most people today don't feel that that is really anything significant at all. And I want to really point that out, because sometimes people will use oral contraception for a few years and want to get off of it because of a family history of breast cancer. Oral contraception is not really felt to be a real strong risk factor by many people. And we still feel pretty good about even using it in people in their 40s. But that is not a very strong risk factor. However, number 3, hormone therapy, on the other hand, something that you would use in a woman who's gone through the menopause, is a factor, but with exceptions. The people that are felt to be at risk are the people who are on estrogen and progesterone. And we give estrogen and progesterone to women with uteruses. We give the progesterone to protect the uterus. And after 3 to 5 years of use, the cancer risk does slightly go up, but it does go up. Now, women who don't have uteruses, we only give them estrogen. And in those women, actually the breast cancer risk after 7 years decreased by 11% in women who are only getting estrogen and not estrogen and progesterone. So it's a difference. There is a difference there. And the feeling is the women just getting estrogen, that the small amount of estrogen alone is acting like a SERM, what we call a SERM. Another area is breastfeeding, and breastfeeding does decrease the risk of breast cancer, especially more than 6 months. If you breastfeed, if you go over a year, that is really good. Alcohol has been known to be a risk factor for some time, and all cancer societies recommend that women should not have more than 1 drink a day to minimize that risk. Obesity is another, being overweight or obese, especially those people who gain weight as an adult. In other words, it's kind of strange, because obese kids who stay obese don't seem to have as high of a risk as people who are kind of normal weight and then hit their 40s and gain a ton of weight. Physical activity has also been shown to be a modifying risk reduction factor, and people who get the recommendation is 45 minutes 5 times a week. Wow. That would be good. That's good for a lot. I don't know anything that physical activity is bad for. It's all good. But that seems to really modify and lower the risk of breast cancer. I wanted to go over the American Cancer Society guidelines. There are guidelines from the other societies, but they differ quite a bit, and there's actually quite a bit of controversy in these guidelines. It is kind of interesting. This fall, in October, the Hickman Cancer Center is going to have a cancer symposium, and we're endeavoring to get one of the people that wrote some of these guidelines that were so controversial to come and talk. And I think it would be of interest for anybody in the system, any medical person, to come listen to what went through the minds of people writing these guidelines that made them so controversial. And I think you'll learn a lot. But I'm only going to go over the American Cancer Society just because of time, and that's not really our focus here today. We're not trying to get into controversy. But mammograms yearly, again, these are people 40 years older or older. So starting at 40, mammograms yearly and continue as long as you're healthy. They also recommend clinical breast exams. That means having a physician or you know, an equivalent a provider do an exam on you, and then the self-breast exams. And then the other caveat here is the high-risk women go farther than the mammogram. And here's where I want to spend a few minutes with you regarding genetics. And I have the privilege of working in the Hickman Cancer Center, and I'm just telling you, I'm plugging this thing. And it's a great little service that has begun. It's developing, and I want to tell you about the importance of it and the type of people we want to see in that cancer genetics service. Family history is a very important determinant of what is high risk. We talked a lot about high risk, you know, people getting radiated in the chest and whatnot. But family history is a very simple thing. It can be hard because sometimes it can be very inaccurate. But family history really is a big deal when it comes to who is high risk. And these are the reasons why. We want to talk about heritable causes of cancer because these carry the highest lifetime risk of developing the disease. You know, people that don't have any risk factors, who are just pedestrians walking around out there, no family history, they have like a 12% chance lifetime risk of developing cancer. Where if you have a heritable cause, if you harbor a gene that could cause breast cancer, your lifetime risk turns into like 80%. So this is a very, very, very important discussion. And I want to talk a minute about how much of breast cancer, and here we're going to talk about the BRCA gene, and it causes people not only to develop breast cancer, but causes people to develop ovarian cancer. So, but I put this slide in here to show you, number one, how much of breast cancer can be explained by hereditary factors. 5 to 10%, that's huge. And not only that, family clusters or big family history, 15 to 20%. Now let me explain the difference between the two. We know of about 12 to 14 specific genes right now that render people at much higher risk for having breast cancer. About 15 to 20% of people, you'll see a bunch of cancer in their family, but we don't detect a specific gene, at least that we know about. And there's a lot of research now going on to find out and to find and define these genes that probably work together or are influenced by the environment that cause people to develop cancer. A lot of research going on in that 15 to 20% right now. The rest of cancers are called sporadic, and the sporadic genes, or the sporadic breast cancers, what happens is you're born with normal genetics, but as you work through your life, what happens is the genetics or the genes become abnormal. And these abnormalities develop later on in life as a cancer. These are typically people, you see them have cancer at the age of 70, 80. You see these people older. And I'm going to teach you a little bit about how to look for the hereditary cancers, because they're much unlike these sporadic cancers. They happen in a younger crowd. Now, the other important thing about some of these cancer genes, and here again, I'm just giving you one example, the BRCA. There's a 1 and a 2 and a 3 and a 4. There's 2 different genes that we look at. And as you can see, they're responsible for giving people a lifetime risk of having up to an 85% chance of having breast cancer. They also give a lifetime risk of developing another cancer in the other breast up to 60%. And finally, a lifetime risk of up to 40% of having ovarian cancer. And also there are other cancers. I want to here's another list of other cancers associated with this BRCA gene: prostate in the male, male breast cancer, fallopian tube cancer. You know, it's interesting that a lot of people now believe that ovarian cancer really starts in the fallopian tube, and it's a changing thought. And some people think that there's some of it starts in the ovary and some of it starts in the fallopian tube. But male breast cancer, fallopian tube cancer, pancreatic cancer is another one. And then other things, colon gastric, melanoma is one that's talked about a lot. So there are other other cancers associated with this specific gene, but the biggest cancer we see is breast cancer, and it gives a very high lifetime risk of having cancer in the individuals. Here's a typical pedigree, and what I mean by pedigree is I'm not talking about a little doggy. I'm talking about a family. This is your family tree in symbols, and this is the tool that the cancer geneticists or genetics people, period, utilize. You know, this is like the colonoscope to the GI guy, or the camera to the plastic surgeon. This is our tool, our currency for helping us diagnose what's going on in a family. And you see a couple things I want you to see here. Every generation has a cancer, and that's because most of these genes are passed on in a dominant transmission. The hereditary pattern is that of a dominant transmission, not a recessive. And what that means specifically is if you harbor the gene, you have a 50% chance of giving it to each and every offspring. So 50% chance of transmission, of a vertical transmission. So you can see where there's going to be a lot of people in the families show up with this gene, as you can see on this demonstration. And on this demonstration, on this example, you also see examples of people with different kinds of cancer: breast cancer, ovarian cancer. I think those are the only 2 on here, but it can be other kinds of cancers. And sometimes, just to kind of give you a head fake, sometimes there's other cancers not related to the BRCA in these pedigrees that can try and throw you off a little bit because people get cancer. But you look for these patterns of these certain types of cancers moving together and in this much frequency. Also, look at the ages of these people mentioned: 36 years old, breast cancer at 40, ovarian cancer at 45. These are young people, and the Chewy Caramel Center in trying to identify somebody with one of these genes is that once we identify people, we can put them in a risk reduction program and really drastically reduce this huge lifetime risk of people having things like the breast cancer or the ovarian cancer. And as you can imagine, there's various ways we do that, including surgery. For instance, in a BRCA case, if you do a bilateral mastectomy with reconstruction, you lower this woman's chance of having breast cancer well over 90%. Wow, that's huge. And then if you take the ovaries out, and we've got all these things worked out, and these recommendations are all worked out, but you take the ovaries out at a very timed interval, then you drastically reduce the person's risk of ever having ovarian cancer. It never goes to zero, and there's reasons for that, but you can drastically reduce people's risk of this. Now, the other important thing is look at the bottom. There are two circles at the bottom. One has an arrow pointing at it, and this person has breast cancer. Look at the sister, which is circles. Circles are girls, boxes are guys. And the other circle is not colored. In other words, that person does not have the gene. They do not have the disease. And it's very important to identify people who are not affected. We recently had a BRCA family in the clinic. Five sisters, 4 of them had the BRCA, 1 of them didn't. And that one person happened to be my patient. And we got a letter and said, you know, she did not go for her special MRI of the breast, and we, you know, they said, well, geez, she's at such high risk, she needs to come in for this. You got to call her. And I said, no, she's not at very high risk. She tested negative for this, and she has the general population risk. I mean, she still can develop it like anybody who has breast tissue. But it's not the high risk that her sisters have because she does not harbor that gene. So it's important to identify people, number one, to help reduce the risk of those who have the gene, and to place the people who don't have the gene into routine screening. You don't have to spend $1 bajillion on these people because they're not going to have the issue. Now, let's go on to colorectal. And just looking at my time, where does all the time go? Now, the modifiable risks, non-modifiable risk for colorectal, again, is age. We see more men having this disease than women. We saw over 100,000 new cases this year, or we will see over 100,000 new cases of colorectal cancer this year. We see another non-modifiable risk is a personal history of polyps or inflammatory bowel disease. Polyps is one of the most common ways that the cancer gets started, and we'll talk more about that. Family history of colon cancer, certainly just that alone, as we've talked about, can increase the risk of colon cancer. And then, of course, hereditary factors, which I will be mentioning more of. Race or ethnicity is another risk. Black individuals seem to have greater risk than all the other ethnic groups. And another ethnic group is the Ashkenazi Jew, or the Jewish people who are of Eastern Europe ancestry. There's reasons for that, but that we will not go over. But that is a very, they have the highest risk of colon cancer than any other ethnic group on the face of the earth. Very interesting. The modifiable risk factors include diet. You know, red meats and processed meats increase the risk of cancer, whereas veggies, fruits, and whole grains decrease. Certainly physical activity, obesity, smoking, alcohol, again, these are all modifiable risks that increase cancer if you do partake. And diabetes, type 2 diabetes, do show an increased risk of cancer. And here again are the guidelines by the American Cancer Society for screening. People who are 50 years or older is the average age risk. We start looking for polyps either with a sigmoidoscopy, barium enema, CT every 5 years, or colonoscopy every 10. It seems as though it takes, if you got a polyp, it's going to take 10 to 15 years to develop into cancer, and that's why that colonoscopy recommendation is there for every 10 years. This is of average risk. And those are the methods used to look for polyps. Now, the methods used to look for cancer are the methods that look for blood in the stool. And there's the fecal occult blood test or the fecal immunochemistry test. Those of us in the ProMedica physicians groups have started using the FIT or the immunochemistry test, which seems to be more accurate than the occult blood test now on people 50 and older. And it seems there's not many false positives and the like. It seems to be a much more accurate test that we're using now. And then that's the average risk. And then you have people who are at high risk getting colonoscopy every 1 to 5 years. And these are the individuals that include the inflammatory bowel disease, people with like Crohn's disease or ulcerative colitis. They're at much higher risk of colorectal cancer than people who do not have these diseases. And then people with the cancer syndromes, the hereditary cancer syndromes, Lynch is one of those, and I'll be talking about that. And so let's look at the risk of colorectal cancer. General population, 6%. This is a lifetime risk. And people with polyps, 5 to 20%. Here's that inflammatory bowel disease, the ulcerative colitis or the Crohn's. Wow, 15 up to 40% lifetime risk, 40%. For colorectal cancer. Now, the Lynch syndrome, or the non-polyposis colorectal cancer, when you have that gene, that gives you up to an 80% chance of having colorectal cancer. And then familial adenopolyposis, the FAP, that's really close to 100%. Most authorities say if you have that, it's not if, it's when. And that is another inherited, that's a gene that you get. And there's these people just have hundreds of polyps, just hundreds of polyps in their colon. And these people actually will develop cancer in their 20s. And so, but you can see that people who have hereditary causes are at, again, the highest risk of developing this cancer. And here is looking at the heritable risk compared to just having a family history. One first-degree relative being, a sissy or a brother or sister or a mom. Your second-degree relatives are getting out to aunts and uncles. And so if you look at, one first-degree relative or one first-degree relatives and second-degree relatives, you can see how the risk goes up. And especially when these first-degree relatives are young, the risk keeps going up. But then look and compare those with somebody who's harboring, again, a gene that expresses this cancer. Again, look at how high that risk is. So what amount of colorectal cancer is hereditary. Here again, about 5% is, that all those little slivers all add up to about 5%. They comprise the hereditary cancers that we know of. Here again, you get a 10 to 30% of these people who have these family clusters of these cancers. And the problem is we just don't know enough about the genes or enough genes to put that together. Again, a lot of research going on in this field. And then you have what we call the sporadic cases, which comprise most of people with the colorectal cancer. And these are the people that, again, these are the elderly that, the 85-year-old, the 80-year-old that comes in and has this new colorectal cancer. It's more than likely, more often, it's going to be sporadic rather than a hereditary cancer. And here again is the a pedigree, and showing this where you see every generation has a cancer in it. And here again you see other cancers associated with this. You see the CRC is the colorectal cancer, but you see ovarian. Endometrial is a huge one. Ovarian's about, if you have a Lynch syndrome, you got about a 10-12% chance of having ovarian. Endometrial cancer, you have like a between a 40 and 50% lifetime risk of having endometrial cancer if you're a woman. So here again you have a list of a number of cancers, and this goes on. There's gastric cancer, there's small bowel cancer, a number of these that are related to this Lynch syndrome. And there are other cancers, again, other genes that can cause colon cancers. And I'm just going over this one example. Incidentally, the corporate, ProMedica, now we've got a program that anybody who has a colorectal cancer that is sent to our pathology department, this cancer is automatically screened, which we can do, and that's another story. But we screen them for the possible presence of a gene. And so we do this routinely now in the pathology department. So it is significant that we, again, identify these people. We, again, can do risk-reducing surveillance on these folks. And it's indispensable to not only to the individual, because it turns out if you have this gene, you're not only at risk for colorectal cancer, but you got these other cancers that you have to be looking for. And not only that, these genes make this more than an individual disease. This becomes a family problem. And again, we try and help families sort this thing out and identify who has, who is not. We try and help them work through some of the emotional, psychological issues that go along with this. And the end result is we hope to significantly impact the amount of cancer. So I think I am at 12:50, and here is a way to suspect hereditary cancer syndromes, cancer in two or more close relatives, early age of diagnosis, multiple types of tumors, as we've discussed. Sometimes they can be rare cancers. Some of these syndromes carry with it rare brain cancers, a lot of stuff. And then there's you see clusters of different cancers together, like breast and ovarian and BRCA, and then autosomal dominant transmission that we talked about. Those are ways that we try. Again, we look for and try and think this person may have a gene that we want to look for. So here are some of the resources. TheCancer.org is a very good one for reading about prevention. And that's all I have to say, Bev, and I'm ready for questions.
Okay, just a reminder, go to the toolbar chat box at the top and type in your question and click on the arrow to have the question go to Dr. Gibbs. Also a reminder, a Zoomerang survey will be coming out, and the code word to receive your CEUs is healthy. Okay.
Dr. Gibbs, there is
Yes,
a
ma'am.
for you. The person asked if a person has first-degree relative diagnosed with colon cancer, should the family members be tested for genetic factors?
If they have a first-degree relatives, first of all, they should be looked at closer, just purely solely on the fact that they have a close relative with the cancer. But to look for a genetic factor, that really depends. I mean, if they are the only person, and there's a pretty big family, but they're the only person with that cancer or with cancer period, it's not as likely. The way we would answer that question is we take this individual's pedigree and we look at, not only the immediate family, but aunts, uncles, nieces, nephews, grandmas, grandpas. We try and get a 3-generation picture of what's going on in that family and all the other cancers involved in that family. Then and only then could we answer them more accurately. Did that answer the question?
Yes. Are there any other questions? If your mother had Crohn's disease, should you have colonoscopies more than every 10 years?
Only if you have Crohn's disease. Crohn's is not a genetic, necessarily a genetic thing. The individual with Crohn's is the only individual who's at higher risk for developing colon cancer.
Okay, here's another one. If you are menopausal with a uterus and do not take estrogen and progesterone, how does that affect your risk when you have 2 siblings that had breast cancer?
Well, it doesn't increase it. It does not increase your risk at all. But you have to separate those risk factors. First of all, you're not increasing risk because you're not taking the estrogen. But the fact that you have siblings with breast cancer, that in and of itself will increase your risk of breast cancer, because those are 2 separate things. And so, again, wow, two siblings with breast cancer. We'd be interested in looking at the pedigree. Again, not only the sibs, but mom, dad, grandma, grandpa, aunts and uncles, nieces, nephews. Has anybody else got breast cancer? Is there any other kinds of cancer that runs in that family? And so, again, more information if we had a pedigree drawn on that family.
Okay, doctor, someone would like to know, did you say they are routine screenings for colorectal cancer for the gene to be able to treat? And if so, why are they not routinely screening for breast and cervical cancer?
Well, the people, when somebody comes into the hospital to ProMedica and they have a known colorectal cancer, and that cancer is removed, there is a special kind of test that can be done. It's not a gene test, but it's a histoimmunochemistry test that can be done that looks at certain proteins. And if one of these proteins are gone, it infers that there might be a missing gene. Now, this kind of test we only know about this for colon cancer. It doesn't. There's not a test like this that exists for breast cancer, and so we don't have anything like that for any. It's only specific to colon, and we screen these colon cancers, specifically these colon. We don't screen for people who come in who have surgery who don't have colon cancer. It's specifically only on colon cancers. And that's all, that we only have a test that exists for colon cancers, not the other cancers. Is that clear?
Okay, another question, does your diet affect colitis?
Oh yeah. You know, I'm not a GI person. I know that it does, colitis is affected by diet, certainly. You know, for specifics, I would refer to, you know, your gastroenterologist who know a lot more. That's not my expertise. Sorry.
Okay, another question. A large polyp found during colonoscope. What is the risk of cancer? Is that for me?
If there was a large polyp found and you got it snipped out, good for you. Kudos. You just beat the disease. And that's how diseases start. And that's why you want to do colonoscope. I think doing colonoscopy is better than pap smears or mammograms because, you know, pap smears and mammograms, you do those, and if you find something, you got to go back and do something. Well, you get a colonoscopy, shoot, they're right there. They snip the polyp, it's gone. You not only diagnose things, but you treat them right then and there. So you've reduced that person's risk of having cancer. The important thing now is that gastroenterologists will invite you back for another colonoscopy in probably 3 to 5 years instead of 10, because they can grow some more. And if you keep going back and you find one or two and you snip them and they're gone, you know, they're reducing your risk of ever having colon cancer. And that's the beauty of colonoscopy. I hope that answered that.
Okay, one more question. How would someone find out if they have one of the 14 to 16 cancer-causing HPVs? By an annual exam or ask the OB/GYN?
What you could do is, you know, I mean, if you've never had an abnormal pap smear, the risk is going to be smaller because, you know, you can do a pap smear and miss something. That is very true. You can miss abnormal cells in doing a pap smear. But when you go get your annual pap smear, if you ask, can I get an HPV culture or assay, you know, I don't know that, you know, I mean, I'm not for sure that it's always paid for. If the pap smear is not abnormal, if it's normal, we usually only do the assays if the pap smears are abnormal. We do the pap smear part first, and then only do the assay if it's abnormal. Now, if you go in and say, I don't care if it's normal or not, please do the assay. You can get that done. The insurance company may not pay for it, but I think you could request it and it be done.
Okay, that is the last of our questions.
Good.
Thank you, Dr. Gibbs, for your presentation. We certainly appreciate it.
Thanks
Just
for your
a reminder to complete the Zoomerang evaluation that will be sent out, and there again, the code word is healthy. Thank you.